Dr. Kalgi is one of our electrophysiologists here at Mayo Clinic in Rochester. He's a really excellent patient advocate, an excellent operator, and has a special interest in autonomics and how it relates to arrhythmias. So welcome and thanks for speaking.
Thank you so much, Dr. McLeod and Dr. Mulpur, for inviting me to speak at the Electrophysiology Board Review. My topic today is going to be syncope, diagnosis, and management. I'm an assistant professor of medicine and senior associate consultant in the Heart Rhythm Service Division of Cardiovascular Medicine at Mayo in Rochester. I have no disclosures for today's talk. So we'll start with some audience response questions. First question is a 21-year-old woman with a history of one unexplained syncope who undergoes a tilt table study. Following a 2-minute prodrome, her heart rate reduces to 29 beats per minute and the systolic blood pressure drops to 40 millimeter mercury with associated syncope. Which of the following is a class 1 recommendation in this situation? Is it initiation of beta blockers? Would you reassure? Educate about the diagnosis and prognosis of the condition? Educate about physical counterpressure maneuvers? Initiate midodrine or admit for further workup? I'll give you all a few seconds here. Okay, we've got a split between education regarding diagnosis and prognosis and physical counterpressure maneuvers. We'll come back to this. Go to the next question. A 24-year-old woman is brought to the emergency room after she collapses in a supermarket. Witnesses describe this as some shaking and slight contusion is present on her left arm. She has had several prior episodes after consuming alcohol or prolonged standing in crowded environments. During these episodes, she usually feels hot, flushed, and has vague malaise prior to the loss of consciousness. And on exam, her heart rate is 70 beats per minute, blood pressure is 100/60. She has normal sinus rhythm on her ECG. What would you recommend about driving? Would you say she's not fit to drive? Would you implant a pacemaker and let her drive? Start driving after 1 month if symptoms do not recur? Or say there are no restrictions? Defer the question to a lawyer or suggest a self-driving car? Okay, so again, a split between a few of these answers. We'll go over this in the talk. Got a couple more. A previously healthy 37-year-old woman came to clinic with fatigue and post-exertional malaise, dizziness, nausea, and intermittent shortness of breath. Echo was normal. Holter showed a heart rate range from 49 to 113 beats per minute. She underwent a tilt table as well and had similar symptoms of dizziness, and near syncope was noted. This was the graph of heart rate, systolic, and diastolic blood pressure. As you can see, the heart rate sort of goes up in the middle of the study, stays up, and then comes down towards the end with mild changes in the blood pressure. What's the most likely diagnosis? Is this inappropriate sinus tachycardia? Is this postural orthostatic tachycardia syndrome? Is it vasovagal syncope, or is this orthostatic hypotension? I'll go back to the graph. And we'll go to the poll. Great, so the majority said POTS and some said vasovagal and orthostatic. And the last one, following effective AED use in the community after witness syncope, which situation is appropriate for secondary prevention ICD implantation? Is it a 51-year-old diabetic female with dialysis-dependent kidney disease, recurrent hypokalemia, and 3 prior Torsades arrests? Is it a 55-year-old male with bipolar mood disorder using lithium, Seroquel, and sinusitis treated with levofloxacin, who was resuscitated after cardiac arrest at his group home, and presiding QTC was 610 milliseconds? Option C is a 19-year-old male resuscitated courtside during a college basketball game, found to have pre-excitation on his first ECG. or a 66-year-old woman with known coronary disease, ejection fraction 47%, and no culprit lesion identified on emergent angiogram. Let's stay on this for a few seconds and then, go to the poll. Okay, wonderful. We have a clear majority here. So today's learning objectives would be to evaluate and diagnose different types of syncope, review testing and management principles, and review management for patients with out-of-hospital cardiac arrest. Syncope is a symptom that presents with an abrupt, transient, complete loss of consciousness, which is associated with inability to maintain postural tone with rapid and spontaneous recovery. There are conditions that are incorrectly diagnosed as syncope, which can be divided into those patients who lose consciousness and those who don't. So with loss of consciousness, you can have epilepsy, hypoglycemia, hypoxia, hyperventilation and hypocapnia, intoxication, and vertebrobasilar TIAs. Without loss of consciousness, you can have cataplexy or flaccid paralysis, drop attacks, falls, functional or psychogenic syncope, or TIA of carotid origin. We know that story is king when it comes to syncope. So when you have a patient with syncope, it's really important to elicit a detailed history. Features that suggest a non-cardiac syncope include patients with younger age, no known cardiac disease, and they have syncope only in the upright position or positional changes from supine to standing. They have specific triggers like dehydration, pain, stressful stimuli, or medical environment. They have a prodrome such as nausea, vomiting, feeling warm or flushed. And they have some triggers sometimes, such as cough or laughing, micturition. And these are quite frequent. In contrast to cardiac syncope, patients generally are older. Males are more predominant to have cardiac syncope. They have known structural heart disease. They have a brief prodrome, such as palpitations, but not quite like what we see with other syncope syndromes like vasovagal syncope. Sudden loss of consciousness without prodrome and syncope during exertion should concern you. They can have syncope in supine position as well, and they're generally less frequent. So certain pearls to look for in history for non-cardiogenic syncope. In epilepsy, patients are generally unresponsive. They have this post-ictal phase related to amnesia after the episode. Psychogenic can have episodes lasting from a few minutes to many hours, and they're high frequency several times a day, often triggered by certain emotional stresses. With cataplexy, these are falls with flaccid paralysis, and patients are non-responsive, yet they are awake through the episode and don't have amnesia. And metabolic disorders sort of depend on the underlying disorder. The duration can be much longer than in transient loss of consciousness, and generally lasts till as long as the metabolic disorders persist. And in cardiac, we can have structural causes or arrhythmogenic causes. In non-cardiac, we can have vasovagal, carotid sinus syndrome, orthostatic hypotension, and POTS. So for structural causes, we won't be covering this in detail today, but just to have a list, we can have valvular heart disease, acute MIs, ischemia, obstructive cardiomyopathy, myxomas that obstruct blood flow, acute aortic dissection, pericardial disease, tamponade, large PEs, severe pulmonary hypertension, and vascular steal syndromes. For arrhythmogenic causes, we talk about sinus node dysfunction, AV conduction disease, supraventricular and ventricular tachycardias, more likely the latter, but sometimes when SVTs, you can have syncope as well. Inherited syndromes, genetic channelopathies, and implanted device malfunction and drug and device-induced proarrhythmias. So for diagnostic approach, again, history is critical. And if it is clear that patients have orthostatic hypotension or reflex syncope on history, then you sort of direct your management to those. If it is unexplained, you do a structural workup to see if these patients have any structural heart disease, which will lead to specific management. So if you've heard of Jerry Seinfeld, this might interest you. So there's this case report where they labeled this condition Seinfeld syncope for a 62-year-old male who complained of syncope and transient left monoocular blindness. He had 3 witness episodes that were all provoked while watching Seinfeld, specifically the antics of George Costanza. And the patient and family were adamant that the syncope has not resulted from any other television sitcoms or the stimuli. On exam, his right arm systolic blood pressure was 45 millimeter mercury lower than the left. And the brachiocephalic artery had a 90% osteostenosis with a 50 millimeter mercury pressure gradient. So that's what that looked like. And eventually this patient underwent stenting of that lesion. And then at follow-up, no episodes have been noted with repeated exposure to the inciting television program. And the mechanism here was felt to be that when the patient saw Seinfeld and he had this hysterical laughter, there was this intense Valsalva maneuver that further compromised flow through that lesion in the in the brachiocephalic artery. So kind of interesting, good to have a sense of humor when you publish certain cases. Evaluation of patient with syncope. For initial evaluation, you want to find out if there's a serious medical condition present or not. And if so, you want to admit them and try to diagnose the condition and treat them accordingly. And if not, you can manage them presumptively for reflex-mediated syncope in an outpatient setting. You can admit them to the ED for observation protocol for intermediate risk. And these are recommendations based on the syncope guidelines. And again, if you have a clear evaluation based on history, you don't need to do further testing. But if not, you can do certain testing. If they have an evaluation that suggests neurogenic orthostatic hypotension, you can do autonomic testing. If it is possible they have a reflex syncope, you can do tilt table testing to figure out what kind of reflex syncope or vasovagal syncope it is. And again, if you are concerned about rhythm abnormalities, you can perform long-term ambulatory rhythm monitoring. You can either do external cardiac monitors or loop recorders based on the frequency of the symptoms, and do structural evaluation and exercise testing based on the patient's history. So we'll focus on reflex syncope now. So reflex syncope, neurally mediated syncope, neurocardiogenic syncope are all really the same. The reflex in this case is one that causes vasodilation or bradycardia or both, leading to syncope. And then you can have vasovagal syncope in this. You can have carotid sinus hypersensitivity or situational syncope. So what happens in tilt table testing? In a normal response with head-up tilt table, you have pooling of the venous blood in the lower extremities. With this, you have unloading of the arterial cardiopulmonary baroreceptors in the carotid body. And as a result, you have enhanced sympathetic activity that leads to systemic vasoconstriction, and the BP comes back to normal. In patients that have neurally mediated syncope, the initial steps are the same, where they have venous pooling and decreased ventricular filling. In these patients, when they have cardiac contraction, it activates mechanoreceptors that stimulate an intense vagal response and stimulates the brainstem, causes sympathetic withdrawal, and then leads to vasodilation, bradycardia, and syncope. And in vasovagal syncope, typically syncope occurs with upright posture, held for more than 30 seconds, with some emotional stress or pain as triggers in certain cases. These patients have a prodrome, as mentioned before, and is followed by fatigue.
Lift from the American people
to show you what it looks like.
Of unaffordable health care. To free families from the pervasive fear that one illness. There you go. You okay? I'm right here. I got you. Yeah. No, you're okay. This happens when I talk too long. You'll be okay.
So it's good there are not too many people in the audience to pass out postprandial right now. But this is what vasovagal syncope looks like. And the role of tilt table here is for the patient who lacks a clear, confident diagnosis based on history alone. If your history is quite clear, you don't have to do a tilt table for everyone. It's a class 2A indication. If there's concern that the patient may have an alternative mechanism of syncope, then that can help as well. If you suspect orthostatic hypotension, now tilt table is not recommended to predict response to medical treatment. So if there's a patient who had a tilt table that was positive, you have a diagnosis, you treat them, and they're having symptoms, you don't have to bring them back for a tilt table to see if they're better or worse than before. And again, tilt table has good specificity. So if you see a positive tilt table, it helps in figuring out the mechanism, but it is not as sensitive. So if you don't see a response, that does not mean the patient does not have the condition. And angle is generally 70 degrees for 30 to 40 minutes. You can give some medications to increase the sensitivity, but they can reduce the specificity of the test. And this is what a vasodepressor response looks like. So where this is the baseline heart rate and blood pressure. And after a few minutes of tilt, you see the blood pressure drops and the heart rate increases. Sometimes you can have a heart rate decrease following a blood pressure drop, but the key component is the blood pressure drop, which is what makes these patients classified as a vasodepressor syncope. And that resolves after you bring them back to a supine position. Cardioinhibitory, on the other hand, are patients that have a predominant drop in heart rate. They can have pauses and sinus pauses, they can have AV block, and the blood pressure drop is the resultant of the reduced heart rate. So it's important to see what comes first. And we have a lot of options for cardioinhibitory patients from a heart rhythm standpoint. So if you have a patient that has vasovagal syncope, guidelines say class 1 indication for education on diagnosis and prognosis. So that was the question I asked earlier. Counter-pressure maneuvers are helpful. They are class 2A indication. You ask them to increase the salt and fluid intake. And if they still have vasovagal syncope, there are a slew of medicines like midodrine, fludrocortisone, beta blockers that can help. The evidence behind all of these is weak. Orthostatic training and SSRIs. And in rare cases, if patients are over 40 years of age, they can be eligible for dual chamber pacemaker therapy to prevent further episodes. That's a class 2B indication. Counter-pressure maneuvers generally work by increasing afterload, and they increase systemic blood pressure as a result and can help prevent passing out episodes. Midodrine is a prodrug metabolized to desglyimidodrine. It's an alpha-1 receptor agonist, so acts via activation of the vascular receptors and vasoconstriction and increases blood pressure. For boards, it is reasonable to use midodrine with recurrent vasovagal syncope with no history of hypertension, congestive heart failure, or urinary retention. That's a class 2A indication. Beta blockers are difficult to tolerate in young patients practically, and they can worsen hypotension and increase fatigue. But again, they do have a class 2B indication for patients over 42 years of age with recurrent vasovagal syncope. Fludrocortisone, you can start at 0.1 to 0.2 milligrams daily in normotensive patients, and you wait at least a couple of weeks to see an effect before deciding to stop the medicine. And again, has a class 2B indication for recurrent syncope. Pacemakers, as I mentioned, over 40 years of age, patients with severe unpredictable recurrent syncope who have a clear cardioinhibitory cause can benefit from cardiac pacing. Now, in the absence of a cardioinhibitory response, if they have predominant vasodepressor response, pacemakers are questionable, and certain algorithms and certain device vendors has been shown to have some benefit, but in practice, it does not always play out that way. So I'll take a couple minutes to talk about cardioneural ablation. I will mention that this is something that is not approved in the guidelines yet, so likely will not make it to the board exams, but it's important to be aware of this therapy option as a promising option for patients with recurrent vasovagal syncope. So we know from knowledge of anatomy that cardiac innervation, especially the vagus nerves, sort of coalesce at this ganglia that are located on the posterior surface of the heart and the septum and near the pulmonary veins. And the vagal nervous system has this feature where the postganglionic nerve fibers are short, so the ganglia located on the epicardial surface of the heart, as in contrast to the sympathetic system where the ganglia are located in the paravertebral chains in the stellate ganglion. So these are accessible via catheter ablation, and for patients that have a hypervagal syndrome, we can ablate these to reduce the intensity of vagal response that they have in some of these episodes. So what we do, and there are different techniques of doing this, but the way we do it here at Mayo is we perform extracardiac vagal stimulation. We take a catheter in the right internal jugular vein through the femoral vein and stimulate the vagus directly. And as we do that, you'll see the surface artifact of vagal stimulation. In this particular patient, there was some sinus slowing and AV block. That was his presentation on loop recorder as well. And then after that stimulation is completed, the sinus rhythm resumes with intact AV conduction. So he had a 7.5 second pause during baseline testing. We performed ablation at the standard locations, and these are generally around the pulmonary vein. So the most common site to increase the sinus rates would be the anterior right ganglionated plexi, which is just anterior to the right superior pulmonary vein and the right inferior pulmonary vein. Then the other side should be the aortocaval ganglia. And then for those that are more AV block predominant, we have to ablate in the inferior ganglia, so just posterior to the right inferior pulmonary vein, in the Marshall tract ganglia, and also in the right atrium near the slow pathway. So we see some beautiful physiology with this. So this patient started out with a cycle length of 1300. And as we are ablating in this anterior right ganglia, you can see the cycle length is shortening during ablation. So sinus rates are increasing acutely. And once we get a permanent response, the sinus rate persists during the ablation and after the ablation. So it's not uncommon to have patients with a 20-25 point heart rate increase from baseline to post-ablation. And after we do the ablation, we perform the testing again. So in this case, extracardiac vagal stimulation no longer produces sinus slowing or AV block in this patient. So I was hoping to do an audience response, but then like a show of hands, but we'll just sort of do it virtually. So 64-year-old male investment banker with hypertension, diabetes, sleep apnea was trying on a new shirt that his daughter-in-law gifted him. He was struggling with the collar button before putting on a tie, and he felt lightheaded and had a pre-syncopal event. Vitals at rest and with positional changes were completely normal. So this is quite obvious. This is carotid sinus hypersensitivity. Then a 78-year-old female with multiple antihypertensive agents, tea and toast diet, presents in June with syncope after she stood up too quickly. Supine blood pressure is 100/70, heart rate 70, goes to 75/55 on standing, and heart rate increases to 90. So in this case, you can see that the blood pressure drops and the heart rate increases, suggesting an orthostatic hypotension as the mechanism. Then the third one is a 24-year-old female with anxiety, depression, who presented after sustaining numerous syncopal episodes, all while standing up. On the tilt table, blood pressure went from 100/70 to 104/72, so modest changes, but the heart rate went from 94 to 140 beats per minute. So the significant rise in heart rate makes this POTS, so postural orthostatic tachycardia syndrome, which was the question I asked in the beginning. So carotid sinus hypersensitivity generally occurs in older patients, more common in men, easier to evoke on the right, and then it causes syncope in 20% of these patients with vasovagal. The triggers can be atherosclerosis, forceful head turning, tight collars, and can occur while shaving or neck massages. If they have a tumor with lymph node enlargement in the area, that can predispose them to syncope as well. A large portion of these have cardioinhibitory kind of syncope, and then these patients do benefit with pacemakers. They can have vasodepressor in about 10%, where they have a greater than 50 millimeter mercury drop in systolic blood pressure with carotid massage. So again, if it's cardioinhibitory, pacing is helpful. You can give them anticholinergic agents like hyoscyamine. You can do propanthyline. Cardioneural ablation is still experimental. We have done one patient who was 74 years old, had clear carotid sinus hypersensitivity, had 8-second pause on tilt table while we did carotid sinus massage. And this was done in March, and it's been about 6 months. He's doing well so far. Hopefully the next iteration of guidelines will include this, and then we'll be able to do this for more patients. For vasodepressor, the options are limited, but again, you can use the drugs that increase blood pressures like midodrine and fluorocortisone to mitigate their symptoms. Orthostatic hypotension, I'll leave these definitions for your perusal later, but essentially a drop in systolic blood pressure and diastolic blood pressure and an increase in heart rate is the classic orthostatic hypotension. If they have neurogenic orthostatic hypotension, these patients will benefit from autonomic testing. And this is not solely related to their postural changes. They have other issues intrinsically wrong with the nervous system. And this is what a classic tilt table looks like, where the heart rate goes up in a compensation attempt and the blood pressure goes down with standing. So if they have orthostatic hypotension, you want to rule out neurogenic orthostatic hypotension. If they have clear dehydration, you give them water and reduce medications that further drop their blood pressure, increase salt and fluid intake. If it's a drug that is causing this, you withdraw the drug and reassess. If it's neurogenic, you perform water ingestion, but also perform autonomic testing, and the medications can be helpful. Non-pharmacological measures, we say at least 240 ml of water, 1 glass of water. Effect occurs after 30 minutes after ingestion. And this is interesting, it's in the guidelines. So the presence of glucose or salt can reduce this effect. So if you have someone with orthostatic hypotension in front of you, plain water actually has more of a blood pressure enhancing effect than giving them sports drinks. This is because it reduces the osmopressor response by splanchnic vasodilation that occurs due to increased osmolality of the fluid reaching the splanchnic circulation. So something that you can be asked, because it's part of the guidelines, as a separate options. If it's clear water versus giving them sports drinks, just plain water is better. As a class 1 indication. And then non-pharmacological with compression garments, again, at least thigh-high can help in blood pressure improvement. In certain patients, they need abdominal compression as well. POTS. Again, frequent symptoms that occur with standing, such as lightheadedness, palpitations, tremors, generalized weakness, blurred vision, exercise intolerance, and fatigue. And then they're diagnosed by an increase in heart rate greater than 30 beats per minute from recumbent to standing position. And they don't have the orthostatic hypotension. The blood pressure may drop a little bit, but generally not to the grade of orthostatic hypotension or 20 millimeter systolic blood pressure drop. Treatment for these, regular structured exercise program has a class 2A indication. Again, we don't have a lot of data on this, and this is what has been shown to be beneficial. And then for patients who have short-term clinical decompensations, you can give them acute IV infusion up to 2 liters of saline to help their symptoms. And important to note, this was on my boards, surgical correction of a Chiari malformation type 1 is a class 3 indication, so you don't do that. You don't perform any sinus node modification or jugular vein dilation. These have been described in the past, but are considered harmful and don't help the symptoms. Inappropriate sinus tachycardia is defined as sinus rates of greater than 100 beats per minute at rest or average rates of more than 90 beats per minute on ambulatory monitors. And these have distressing symptoms. Typically, they don't have syncope as much as they have just palpitations and a sense of their heart rate going up while they're resting. Again, you want to find out reversible causes if they exist and reverse them. Exercise program can be helpful for these patients as well. And beta blockers and ivabradine can be helpful. And again, sinus node ablation or modification is not recommended. For rhythm monitors, if patients are older, they have recurrent syncope and don't have a clear diagnosis, you can perform loop recorders if their symptoms are less frequent, or external monitors if they're happening every other day, for example. And they are at a low risk of fatal outcome. So you can perform longer-term monitors for these patients as a class 2A indication. Now, if you have patients who you clearly suspect an arrhythmic etiology, and then their syncope symptoms are happening more frequently or more concerned about them, or they have structural heart disease, an EP study can be helpful in delineating the mechanism of syncope in these patients. It is not recommended for patients with normal ECG, normal cardiac structure, unless you have clear suspicion of an arrhythmia. Autonomic evaluation, again, if you have someone that has neurogenic orthostatic hypotension or neurodegenerative disease, you can perform autonomic evaluation for them. I put the driving restrictions here. These were not on my boards, but then again, the guidelines have been out for a while, and then this question comes up in practice quite a lot. So it's fair game for a board question. So if you have vasovagal syncope and no syncope in the prior year, you don't need to restrict them. But they're having 1 to 6 episodes a year. You do 1 month restriction and reassess. If the symptoms are better, you can lift the restrictions. If they have more than 6 episodes per year, they are deemed not fit for driving. If it's just bradycardia, if they get a pacemaker, they can drive after a week, but if it's untreated, they're not fit. Presumed supraventricular arrhythmia, untreated, not fit. If they're suppressed with medications, you do 1 month. If you ablate them, they can drive after 1 week, and these are patients that have syncope related to these. Presumed ventricular arrhythmia, if they have no ICDs, medications, or ablation, they are not fit. If they have an ICD or they get ablation, you can let them drive after 3 months. And if they have ICD shocks, despite this, you have to wait 6 months before you let them drive. So just some pearls for boards. Any syncope that is not treated, you cannot let them drive until you figure out what's going on. If it is treated and no recurrence for 1 month, generally okay to drive. Syncope with low ejection fraction or due to VT, VF, and no ICD, cannot drive. There's syncope with ICD shock for VT, no driving for 6 months. There's ICD shock without syncope. They can drive after 3 months if provided they have no further episodes. And professional drivers, so truck drivers, commercial drivers, cannot drive if they have an ICD present. So these are all fair questions for boards. So switching gears to sudden cardiac death for the last few slides, the concern here is that majority of these events happen in the general population, and the incidence in that population is quite low. So it's like picking a needle in a haystack. And when you look at patients at a higher risk, ejection fraction lower than 30%, cardiac arrest survivors, within them, so the proportion of sudden cardiac death is high, but compared to the total number of sudden cardiac death events, their event rates are low. And that is a challenge in risk stratifying the general population for sudden cardiac death. patients that have out-of-hospital cardiac arrest, majority of those that are diagnosed end up having ischemic heart disease. Non-ischemic cardiomyopathy can amount to about 20% of these conditions and 5% with congenital conditions. Most common presenting rhythm is VT-VF, more than 80%, and the others have asystole or PEA. And I thought this was an interesting study done in Canada in 2016, where they looked at out-of-hospital cardiac arrest, and this is the CASPER registry. So what happens when we get patients with out-of-hospital cardiac arrest? We admit them to the CCU, we evaluate them, everyone gets ECG and some kind of imaging like echo and maybe an MRI. But how many of these patients where you don't pick up something are you putting on a treadmill? How many patients are getting genetic testing? If you're concerned about Brugada, how many are getting procainamide study to unmask a Brugada ECG pattern? So these are tests that we don't do routinely in everyone, and this registry urges us to do them, because when you have all of these patients that were initially undiagnosed and they perform this cascade of testing, more than 40% of these patients were diagnosed with the condition later. And this was in 2016. Our genetic tests have improved since then, and they're better covered by insurance. So something that we should consider for a lot of these patients before discharging them without a diagnosis. So for those that have ischemic heart disease, if they are SED survivors with sustained monomorphic VT, and if they have ischemia warranting PCI, then you perform that and you reassess the risk. Now remember, monomorphic VT is related to underlying scar tissue. So if they have, even if you revascularize them, their risk is still there. So you want to assess them like you would any other patient, and they'll be at a higher risk since they've already had a cardiac arrest episode. And if they don't have any ischemia requiring PCI, if they're an ICD candidate, that's a class 1 indication to give them an ICD. If a patient has clear cardiac syncope based on your history, and the ejection fraction is less than 35%, that's a class 1 indication for ICD as well. If the EF is mid-range, if it's 40-45%, it's reasonable to do an EP study. And if they have inducible arrhythmias on that, they get an ICD. These questions always come in the boards. I think I had 2 or 3 questions about this. And if it's non-inducible arrhythmias, but you have some concern based on structural heart disease, you can perform extended monitoring. So if they have reversible causes, and these patients generally don't require an ICD. So patients with pre-excited AFib, you have a talk on SVT syndromes later, and I suspect one of these will be shown. VT or polymorphic VT within 48 hours of an acute MI, not an indication for an ICD. Drugs or electrolyte abnormalities where there's a clear reversible cause, they don't need an ICD either. Or if they have arrhythmias that are amenable to ablation in structurally normal hearts. So idiopathic VTs like RVOT, VT can be ablated and can be monitored before making a decision regarding ICD or not. So certain take-home points here. So pay attention to the clinical presentation and syncope. History is the key factor. Identifying risk factors will lead to appropriate diagnostic testing. Be aware of the guidelines. Now we have the ACC guidelines from 2017. We have ESC guidelines from 2018. Go over these documents. And for those that are used to phone apps, both of these have phone apps. The guideline app is a quick review. Certainly do that before you sit for the boards. Follow a systematic workflow for patients with out-of-hospital cardiac arrest to improve the sensitivity and specificity of diagnosis and for secondary prevention. I'll stop there, and I'll just mention these guideline documents I used to create today's talk. We'll go back to the questions we started out with. So first question was a 21-year-old woman with a history of unexplained syncope who underwent a tilt table study. Following a 2-minute prodrome, heart rate went down to 29, blood pressure went down to 40 with associated syncope. Which of these following is a class 1 recommendation? You know the options. We can go to the poll. What is it? We have to hit 80% for you to let me go, or is there a cutoff? No? All right, 71%, better than where we were. So yes, education on diagnosis and prognosis is the class 1. Counter-pressure maneuvers are helpful, but these are class 2A recommendations on the guidelines. Go to the next question. A 24-year-old woman is brought to the ER after collapsing in a supermarket. She had some shaking, contusion on her left arm, several prior episodes, more than 6, consuming alcohol or prolonged standing in crowded environments. During these episodes, she usually feels hot, flushed, and has vague malaise. Heart rate, blood pressure normal on current exam, ECG is normal. What is the driving restriction for this? So she's had multiple episodes and you haven't treated it yet. Okay. So this patient, if you think about what's going on, it is vasovagal syncope. So according to the guidelines, they say if you have multiple episodes within the last 6 months and you initiate a treatment program and you wait a month, you restrict them for a month, and if they're feeling better, you can let them drive. If this patient had ventricular arrhythmias or had an ICD and getting shocked, those are the ones that you say are not fit to drive. Or if you say you're not treating this at all, those are the patients not fit to drive. So maybe not, I should have mentioned the fact that we are initiating treatment now, which makes 1 month driving restriction more appropriate. A previously healthy 37-year-old female came in with post-exertional malaise, dizziness, nausea, and echo was normal, Holter was normal, underwent a tilt table with reproducible symptoms, and this was the tilt table graph. Heart rate goes up, a mild drop in systolic and diastolic blood pressure. What's the diagnosis? We better hit 80% on this one. All right, 81%, good. So this is POTS. So you have an increase in heart rate. Remember, vasovagal syncope, you'll have a drop in heart rate, a drop in blood pressure, or both. Orthostatic hypotension is the closest to POTS, but then you have a decrease in blood pressure with the increase in heart rate. So the decrease in blood pressure is not present in POTS and has to be more than 20 systolic or 10 for diastolic. And the last one, I think most of you got this right already at the beginning. I won't go through this with the poll, but then this is the 66-year-old woman, structural heart disease, slightly low EF, no culprit lesion, and had syncope. So this is the likely out of these options who'll end up getting a device. And you may do an EP study to see if she has non-sustained or sustained VT. But of all these options, the others had reversible causes. So it's answer D. Okay, I'll stop there. Thank you very much for your attention.
Guru, thank you very much for that wonderful overview.
Thank you.
Even though I try not to speak about POTS, and I, as an electrophysiologist, wish they wouldn't come to my clinic, and I'd much rather see VT and arrhythmias themselves. We can really help these patients. They obviously end up in our clinic a lot. They're part of our guidelines, and I think that, and maybe this is me putting in a plug, and I'll bring you into the question in a second, but me putting in a plug for so many of these patients feel like they are misdiagnosed, misunderstood, misled by other invasive testing, non-invasive testing. And I think this is an opportunity for electrophysiologists to really, the buck stops here. There are excellent programs around the country from an educational point of view where these patients don't need any more testing. They've had so much testing already. They've had a loop, some of them have a loop recorder, they have ambulatory ECG monitoring, they've had 5 different echoes, they've had lots of different ECGs, and we can quite confidently say they don't have an arrhythmia. Doesn't mean that they don't have a syndrome, and the syndrome can be really debilitating. And so real structural changes seen in the cardiovascular system by Ben Levine's group, which is really fundamental in our understanding of their deconditioning and how we treat them. But I think it's really an opportunity for the electrophysiologists to say, great news, we don't need to do an ablation. We don't need to intervene with drugs. You're going to do well. There's very little mortality and patients are going to recover. And just those few things, and then giving them some information on the stuff that you mentioned, and how this is really a hyperadrenergic state. Yeah. Very common post-COVID. The long COVID syndrome has a lot of these overlap components. And really, I think, no real intervention for an electrophysiologist who wants to ablate arrhythmia.
Yeah.
But they come to your clinic all the time. Where do you start off with them?
No, absolutely. I think you hit the nail on the head with the psychological component of this, because I feel when they get misled for many years, sometimes before they come to us, they sort of have this mistrust in the provider, and then it's oftentimes, like you said, just reassuring them. And a structured exercise program it's interesting that despite all of this, no one's ever spoken to them about the structured part of it. They'll tend to go exercise, but do what? So again, it's important to have a program built in within heart rhythm, which we don't have at this point. Something like a cardiac rehab, which is covered by insurance, where we can perform observation for these patients, gradually increase the intensity of training, watch their heart rate, blood pressure as they do it. As they get more conditioned, their heart rate slope decreases, their heart rate decay gets better, and they have an improvement in symptoms. And this is something that we should be focusing more on that compared to a lot of the other testing that unfortunately gets covered. So you're right, and I think we should be accepting of these patients, and the first visit is generally just reassuring them and developing the trust. It takes a few visits for them to believe in what you're saying, and then once they start doing it, they see the results, they get motivated after that. But it is one where we have to have a close link with our neurology colleagues as well, because POTS can have some subtypes that are more central nervous system predominant. So it's important for them to also visit with the patient at the same time, and again, giving them hope and telling them that this can be cured is the best way to go about it.
Yeah, I agree entirely. So moving then to the vasovagal neurocardiogenic syndromes, here we have real effects. We've had some terrific results with our ablation, but obviously for boards, your first approach is never going to be ablating for vasovagal syncope. This is still in the early phases, and there's exciting results. I saw that cardioinhibitory pause that you demonstrated, which we've seen commonly. We've also seen quite a bit of change in blood pressure. So, and you had a slide there which was maybe for the cardioinhibitory. Mm-hmm. We've seen patients that don't have the cardioinhibitory component, but they've got vasodepressor. Yeah. You start ablating in some of those regions, which you nicely showed, and you see the blood pressure just go way, way, way up. Yeah. So starting at 110 and all of a sudden it's 180, and they're under general anesthesia.
Right.
So you've got a real opportunity maybe to interact with the vasodepressor components, and some of that's starting to emerge. But definitely for boards, this is further down the road. Management of the event, meaning don't stand for a long time watching presidents speak in the hot sun while you're pregnant.
Exactly.
And also just managing your awareness around that, and you can generally avoid some of these events from happening.
Yeah, absolutely. I think for boards should stick to that, and I'm hopeful the next iteration of guidelines will have cardioneural ablation because the data is so strong, and our own personal experience has been fantastic. So, and like you said, we've done about 25 of these, and about 3 or 4 had a predominant vasodepressor response. And the thought was that I was thinking maybe, yes, I've seen the blood pressure increase during ablation, but also if we can increase their resting heart rate, the threshold at which they'll pass out will be a little higher. So maybe they need more of a blood pressure drop to pass out because their resting blood pressure also goes up. So yeah, I've had reasonable success for those patients, but definitely better for cardioinhibitory. Hopefully our next board review will be including that if that's part of the guidelines.
Yeah, and then the last thing to circle back on, and I think it's an undertreated aspect of clinical electrophysiology, was exactly what you showed there with the CASPER registry. So that was that Canada study. Any patient that's presenting with out-of-hospital cardiac arrest, we really need to do our best to find the cause. Mm-hmm. It's very rare, and as they showed there, that there's no cause if you dig. So procainamide challenge or flecainide challenge, trying to unmask Brugada, definitely exercise testing, making sure that there's a good family history, epinephrine challenge. Some of those patients we've had, I can think of not just the long QTs that we've unmasked or subclinical concealed channelopathies, but also coronary vasospasm. You give some epinephrine, you get ST elevation. So there's lots of things that I would recommend the listeners or watchers just to have a look at that registry. There's some excellent data there.
Absolutely.